Yeah, so today we're going to talk a little bit about a new, what we consider a clinical care pathway that we've been working on for, it's been like about 5 months now. Yeah. We elected to do spinal cord injury first because it seemed like it was probably one of the more straightforward ones that we could get a lot more consistent buy-in from all the people involved. So let me just see if I can figure out how to use this. There. So some of the objectives of the presentation are to explain why we decided to do this, also explain the efforts behind developing this clinical care delivery standard, introduce the items that are included in the standards, inform the staff of where to find them for further education and knowledge awareness, and then finally to address any questions or concerns about the particular process. So one of the first, sorry guys, this is my first time trying to do it this way, so is, why was this important? What we wanted to do was, what we did was identify that there was no consistent standard of care throughout the system, so across and within service lines and geographic regions. And I think what you're going to see is this is going to be just a smaller part of a larger project. I think that so far I'm familiar with a handful of different processes that are occurring. One of the groups is, again, also, or is looking at stroke and looking between all the service lines and how we can create a continuum of care that's more efficient. And then also, but this is looking specifically at rehab in both the Magic Valley and the Treasure Valley and trying to get some standards more consistent between the two. We also recognize that this particular population would have the greatest benefit from having a standardized set of care, and they were also the most at risk for any negative implications that might occur without that standard process. Clinical leadership also saw this as a way of developing value in these, or when caring for these clients. And then finally, developing guidelines and timelines we thought was going to be very important to make sure that we were addressing all the needs of the patient or the client that we thought we needed to address. I think everyone can agree that many times we do a great job 80% of the time, but sometimes we might miss getting a wheelchair prescribed in a timely manner or addressing skin or pulmonary issues within a certain time frame. Even like the ASIA is something that routinely comes up as, are we establishing an ASIA official diagnosis at the right time in a client's plan of care, and then building our treatment plan off of that. So developing the standards again. So what a group of people got together between St. Luke's here in the Treasure Valley and the Glenn Nielsen Anderson Center in Magic Valley. There was a variety of disciplines involved, including nursing, OT, and PT. Directly involved, I know I reached out to Tammy for some of the standards that I thought that I felt like speech therapy should really own. Topics were identified on, what we thought would be appropriate for establishing these standards, and then we just divided it up between the two groups, the one at Magic and the one at Treasure Valley. The work groups brought back basically a plan, and you'll see what those look like. And then we had that approved by all the stakeholders, specifically medical and program directors. So with regards to the standards for Treasure Valley, we took on pulmonary care, cognition and swallow, functional progression, expected outcomes, ASIA administration, complex rehab mobility and seating and positioning, and then DME provisions, which actually we broke out into two different standards because they had very different needs. Adjustment to injury and role participation, whereas Magic Valley took on bowel and bladder management, circulation, skin care, general complications, caregiver and family training and education, and then sexuality and intimacy. So at the moment, there is no specific location that a final copy of these standards are located for your knowledge and for you to read through them and take a look at the timelines and brush up on all that stuff. My expectation is that we'll just build a folder that will be designed for this, and then also we'll have a hard copy resource for people to look at. My expectation is once Magic Valley entirely wraps up their standards and we bring everything together into one single document, we'll store it on the shared drive so that everybody can go to it. This, I think, will be a great resource for people who routinely treat clients with spinal cord injury on the inpatient unit, but also people who are recovering and just want to know a little bit more about the expectations. So, I'm just going to take you to, oh, seriously? Is that right? No, doesn't look like it's on. Well, let me see if I can get out of this. Out of that. Actually, let me just bring the document up here. It was hyperlinked, but because I think the way this presentation works, that's not it. That's it. So we'll just go, I'll show you guys a few of the standards and we'll go through a couple of them. If you guys want to spend time looking closer at them, I'm happy to review them with you right here. Okay.
Show one.
I'm sorry?
Show one.
That's okay. So here's the Treasure Valley ones, the ones that we took on. You can see the pathway areas and the therapists or the disciplines that will take primary responsibility of that particular standard. The first one on that list, let's see. So if we go down to this first one, this is the functional progression and expected outcomes. The objectives are to, number one, but utilize expected outcomes based on a patient or an individual with a spinal cord injuries diagnosis to set the stage for what to expect in their plan of care. I think there was a little kind of gap between discussing what kind of areas clients would be able to hit effectively and expecting with regards to functional mobility as well as ADLs. So that was one of the objectives. The other objective was to establish a relatively consistent functional progression of activities to work on with the clients when they're on an inpatient level. So I think where that really comes in nice is for the clinician who doesn't routinely work with individuals with spinal cord injury, but is familiar with that functional progression. They kind of have an idea of what areas to work on and what areas are outside that client's current level of abilities. Resources that we used for that were the Paralyzed Veterans Association's clinical practice guidelines for expected functional outcomes that were developed by the PBA model centers. There's a continuing education course that establishes the functional progression, and that's the SCI seminars that Casey just recently attended. I went to about a decade ago, but I found it incredibly useful and really helpful in advancing a client's level of function. And then Martha Summers' Spinal Cord Injury Functional Rehabilitation book. So the recommendations here, and you can see these recommendations are relatively general, where some of them are going to have a little bit more specific timeframes. But the recommendations are that the expert practitioner would discuss expected functional outcomes within their field of practice with the client based on those recommendations. So the therapist would sit down and review those recommendations with a client with a new injury so that everyone was on the same page on what their goals were for that specific time frame. And then the recommended functional progression of skills would be followed, but also we understand that not everybody's the same and some people do better in certain things than others. So we would adjust and deviate from that based on the individual's specific presentation and abilities. The last little comment there is any education that is specific to the standard that will be delivered at a near future date. So if we just go into, we can spend some time on pulmonary care for a second. So the purpose was, again, to create a guideline to provide required pulmonary care to individuals with spinal cord injury that was organized and specified. Respiratory therapists would take ownership of this particular pathway. At the time of admission, the admitting physician would determine if they had pulmonary care needs. If it was appropriate, within 24 hours, or they would actually place the order, and within 24 hours, the respiratory therapist would act on that order. So they would evaluate their pulmonary status within that 24-hour period. So now we've got a time frame that we can kind of stay up with the service instead of trying to inject it where we can. The respiratory therapist would determine the need for pulmonary care based on the risk. They would draw a plan of care in EPIC that would categorize the risk and establish specific instructions. And then the rest of the disciplines would follow off those instructions, or provide those interventions based on the plan of care. And then only the respiratory therapist could discontinue this particular set of orders if they felt like the client no longer needed respiratory or pulmonary care. So this one's very specific to the provision of mobility equipment, specifically power and manual wheelchairs and seating components. Again, you can see the time frame in there. Within 24 hours of admit, which this is something that we already do. We determine an appropriate chair and cushion. We do that at the time of the eval. That's based on what they need while they're here in the hospital. But within 2 weeks, PT has a pretty good idea of what definitive equipment they're going to need at the time of discharge. The PT coordinates with the vendor to arrange for a trial and prescription within 2 weeks. So now we've set a time frame of, in 2 weeks, all this mobility-related recommendation is actually relatively nailed down. So we're not 3 weeks before discharge still trying to problem solve where they're going to be. The PT and the vendor and the patient are scheduled for a demo and prescription within those first 2 weeks. There is a piece of loaner equipment that's arranged for and delivered prior to the patient's discharge. Our current process is within 2 days prior to discharge, 24 to 48 hours. And then the PT obviously would complete the required equipment justification documentation prior to the patient's discharge from the facility. Now that doesn't necessarily mean that they've acquired their system before discharge, but what it does mean is that everything's been prescribed and the letter of medical necessity is completed. I'll just go through a couple more from the other disciplines. So here is DME with occupational therapy. Again, 24 hours, the OT is to assess the shower chair and or toileting DME. Within 2 weeks, the OT will have completed trialing of various equipment. And by the end of that period, it is determined which DME is required of discharge. OT would collaborate with case managers to determine possible funding sources. If a vendor is utilized, OT and the discharge coordinator coordinates with the vendor to determine the need for in-person any meetings that would be required to acquire the DME. And then the OT would complete the letter of medical necessity. Any DME that it doesn't require a vendor, the occupational therapist or the case manager would provide local resources. 1 week before discharge, PT would manage hospital bed prescription, so filling out paperwork for a hospital bed as needed. Nursing provides documentation for air mattress overlay as needed. And then by discharge, either the family and the patient have acquired the DME, or that the process is completed and just awaiting insurance approval or any other logistical issues. So, and then finally, I did want to touch on the speech one. So, we do recognize that especially high cervical injuries, there's a lot that speech therapists can do, specifically whether you have a dual diagnosis where they're working on cognition or you just have voicing and swallowing issues. That's very much speech therapy's forte, and they have a lot to offer with regards to helping these clients develop the breath capacity to voice themselves in a better manner that makes them feel more confident and helps them be heard. So, if the patient enters the rehab hospital with speech orders from the physician, they schedule a speech evaluation immediately with the PT and the OT evaluations. If they aren't ordered, but the treatment team or the physician observe deficits in cognition, speech intelligibility, language, and swallowing or voicing issues, and they would be considered new deficits. I'm sorry, I'm not as familiar with this particular one because it's a little out of my scope. So, if they feel that a speech evaluation is needed, an order is put in place within the next 48 hours. So, at the first staffing, treatment team confirms whether or not to involve a speech in the treatment team. The nature of the deficit is specified in the order. The evaluating SLP reports to scheduling on the frequency of speech therapy that is recommended. So they take full ownership over this piece and ensure that it actually gets completed and done. So, again, so if we go down here to adjustments, this is actually social work's domain that they're going to take ownership of. So, again, they will be within a week of being admitted to the program. A social worker would be scheduled with them versus whenever they could get on the schedule. It would actually be required that it happens in a specific time frame. And then counseling services would be scheduled if it was determined that they were necessary. And only the counselor or the social worker are able to just discontinue that specific service. And then the last one on the list is role resumption, in which the recreational therapists get involved within the first week, establish goals, and then help those clients address means to achieving those goals. So that was, I'm going to leave that up for a second. And so yeah, this is my last slide. Is there any specific questions about this process?
Just a couple of comments real quick. I want to thank Cassandra, Casey, Cece, Joe, Tammy. I didn't see you. I didn't know you were participating. Christine, but really, Cassandra, Cece, Casey, and Joe really did a lot of work putting this together from the Treasure Valley. There's been work going on Magic Valley as well. A lot of this stuff we're already doing, but it is also designed to get the rest of the team on board with it. Nursing being a huge component. And I mean, I think I see it now more in staff, and I don't hear quite as much of people not starting childcare until the third week or having quite the issues as we were having. You guys remember a couple years ago, I mean, it was kind of a mess as far as some of our spinal cord patients